Hello, everyone. Bonjour tout le monde. Apologies for the delay. We're held up a little bit by some technical issues this morning. Je m'appelle Dominique Charon et je suis la vice-présidente programme et partenariat du Centre de recherche pour le développement international du Canada. Welcome again. And our session today is on the power of global innovation and local intervention to tackle COVID-19. With great respect, before we begin, I'd like to acknowledge that I am speaking to you from Ottawa, Canada, which is situated on the traditional and unceded territory of the Algonquin Anishinaabe people. I would also like to recognize that many of you are joining us today from other places, near and far, and acknowledge and thank the traditional owners and caretakers of those lands. As part of Canada's Foreign Affairs and Development efforts, Canada's International Development Research Centre, or IDRC, champions and funds research and innovation within and alongside researchers in developing regions to drive global change. From time to time, we collaborate with Canada's research councils, notably in response to public health emergencies of international significance, such as in the past outbreaks of Ebola or Zika virus. Thanks to this experience, IDRC and the research councils were very ready to rapidly mobilize research funding in response to the emerging novel coronavirus pandemic that was to become known as COVID-19. As early as February 2020, Canada was among the first countries to mobilize research funding opportunities that included international collaboration with low and middle income country research organizations. And this initiative was led by our good colleagues at the Canadian Institutes for Health Research, or CIHR, but IDRC was there to help catalyze that international dimension. This opportunity was then rapidly expanded to a second round of research funding in April with more than $150 million. Leveraging this expertise in Canada as well as internationally for innovation and knowledge from coast to coast in Canada and the robust network of research partners around the world, this initiative that we'll be discussing some results from today led to rapid response research. And these long-lasting solutions that we're going to be hearing about today have application both in Canada and internationally. IDRC also mobilized more of its own funding in response to the pandemic in 2020, eventually $54 million, or half of our annual programming budget, toward all dimensions of the pandemic's challenges, including social and economic policy gaps, gender and other inequality challenges, food insecurity challenges, and how the deployment of advanced technologies such as artificial intelligence could be used to help both understand and respond to the pandemic, as well as understand and respond to social and economic challenges. More than 60 IDRC-supported research projects are studying the impacts from this funding, and not only studying the impacts of the pandemic, but developing solutions. The panelists today will share results of these partnerships between eminent researchers in Canada and low or middle income countries. They will present also both global innovations as well as local interventions working with marginalized or vulnerable groups, such as people who identify as LGBTQ+ or refugees. Through this panel discussion, IDRC is bringing together the projects from Colombia, India, Peru, Thailand, Uganda, and Canada, and we hope the conversation will be rich around how innovations and interventions are changing the face of the pandemic. The panel will be in English, and I'm making my remarks in English today since our speakers do not speak French, mais sentez-vous libre de poser vos questions en français ou d'accéder les outils de traduction simultanée. So we will hear today from César Ugarteguil, and I think I'm supposed to share my screen here so that you can see the slide. However, I'm worried that I'll lose you. So I'm going to introduce the speakers and then we'll go directly to them rather than show the slide. We have César Ugarteguil, who is from the Universidad Peruana Cayetano Heredia in Lima, Peru. Camila González Rosas from Universidad de los Andes in Bogotá, Colombia. Robert Pizza from the Young African Refugees for Integral Development, YAGID, in Kampala, Uganda. Carmen Loki, who's a Factor in Wintosh Faculty for Social Work at the University of Toronto, and apologies, Carmen, if I've mispronounced your name. And Peter Newman, who's also with the Factor in Wintosh Faculty of Social Work at the University of Toronto. And they will be speaking also to their role in the project in Kampala, as well as in Chiang Mai, Thailand. So with that, let me just to give you a little bit more detail about Professor Ugarteguil. César is an assistant professor at the University Peruana Cayetano Heredia in Lima, Peru. He's been working extensively in infectious disease clinical research and has a background not only in medicine, but also in epidemiology from the London School of Hygiene and from Johns Hopkins. His work on infectious diseases has focused on TB, HIV, and tropical diseases, and he's going to be telling us about rapid diagnostic tests this morning. César, over to you.
Thank you, Dominic. Good morning, everyone. Thank you for the opportunity to discuss our project that was funded by CIHR. A little bit of context. Peru background is, remember that COVID-19 unfortunately affect, but Peru was unfortunately had one of the worst numbers in the pandemic. We are right now more than 2 million reported cases. We are over right now 200 deaths, and Lima, for the region I live, and the third part of the population lives in Peru, is the region with the highest prevalence. The TB incidence in Lima, to put the context about COVID-19 in the moment, was 88.8 per 100,000 in 2019, but in 2020 was 65.7. These numbers, this reduction, no means that TB reduced. The problem is COVID-19 affects so hard health system, then the detection and diagnostic of TB was reduced a lot. We calculate with the National TB program is around between March 2020 to October 2020, 8,000 cases of persons with TB was not detected. So this means that these persons meet at home, at work, etc. And right now, as you see, with the pandemic in the second part of the slides, is the problem is not only in whole the country, it's in Lima, and the reason is TB detection usually is in primary care clinics, and primary care clinics were closed almost during all the 2020. So imagine that not only TB, it's child care, maternal care, etc., etc. So we start to discuss with the team. This is a team from people from McGill University in Canada and our team in Cayetano Heredia University in Lima, how to use the platforms that already exist to start to detect both and TB. And one of the options that we look and we have experience is the expert platform. You see, we saw the new one, the white one is the new one, but the other ones has more than 10 years of age, these machines, and they work very well. We, as one of the sites, then tested expert for TV. So we have a lot of experience and we know that we can use it. And also during the COVID-19 pandemic, expert platform start to show that also can be a diagnostic option. So the objective was determine if the diagnostic accuracy of Expert Express SARS-CoV-2 in adults with presumptive COVID-19 and or TB. Because the idea at the end is try to see if we can use a one sample for two diseases. And objective two, that giving a differential diagnosis of COVID-19 or TB using a single respiratory sample of on Expert Express SARS-CoV-2 or an Expert MTB RIF Ultra in adults with presumptive COVID-19 and or TB. And why is the reason? Because also we start to detect a lot of people with co-infections for COVID-19 and TB in some of our patients. In the National TB Program reports in 2020, 2,200 more or less patients with co-infection. So the recruitment study design, the 2,200, sorry, is nationwide, so in whole the country. Recruitment study design, we decided to go to a very high prevalence sites. No, San Juan de Lurigancho is the biggest district in Lima, almost 1 million persons. Is another area in the east of Lima, very close to the highlands, and also is an area with a lot of unfortunate poverty, and they have a lot of TB, and was the areas with a lot of problems with COVID-19. La Victoria is in the middle of the city, and is one of the areas with high levels of high prevalence of TB, but also was the area, one of the areas with highest impact of COVID-19. So the idea the sample size we want to collect is 650 participants. The data I will present today is for almost 500, and it's adults with presumptive TB and COVID-19. So this is the idea. We try to get a nasopharyngeal swab, but also a sputum. A sputum is the sample that we use for the TB. And the nasopharyngeal swab was the use of the sample that we use for COVID-19. And the idea is, at the end, as I explained before, is try to see if we can use one sample to test all both diseases, no? But we try to standardize this using all the samples available. So the study population is more or less, and the age is around, the median age is 39 years old. The around 8 days, the median days, and the severity is mentally ill. It's not, we don't enroll a lot of severity cases, fortunately. And one of the things we found is that in Peru we don't smoke a lot, so probably is a risk factor that don't affect that, but we have a lot of other chronic diseases, no, disease, asthma, etc. So one of the things we found is the prevalence in this small population, TB around 11% and 30% for COVID-19. And this is using the gold standard test, the RT-PCR for COVID-19, and for TB was the Ultra. And we start to find also a lot of people, when we start to count, is when they combine Ultra and RT-PCR, we found 4 cases of TB COVID. And Ultra and RT-PCR in sputum, we found. And when we start to combine Ultra, then this is the test for expert for TB, and Express, then this is the for the expert is 10. So the story here is maybe we can start using one platform to detect these two diseases is it's a good idea to try to reduce the time. Remember that these platforms have results. So in 2 hours, we can have the results from both diseases. And the sensitivity is very, very well. When we compare the sputum in the expert cartridge with RT-PCR, the sensitivity decreased to 83%, but it still is that. And when we combine, for example, expert cartridge for COVID-19 using a sputum versus RT-PCR, combining nasopharyngeal and sputum is 98%. So all the combination shows that this platform can be a nice opportunity to use not only nasopharyngeal test that is very invasive and is complicated sometimes, etc., and also have risk for transmission, but we can use a sputum that is more simple sample. And we identify when with single sputum specimen, use only one single sputum, we detect 83% of the COVID-19 cases and 98% of TB cases. So imagine that we only request one sputum sample and then divide in the lab for these two cartridge. We found a lot of the cases that probably have COVID-19, TB, both infections probably. No? Ongoing work, we are for recruitment, we almost finished. We are collecting the last data. We are doing 3-month follow-up phone calls to confirm the diagnostics in the cases that have negative results. We are also, we sent a proposal for expand this cohort because we found very interesting to continue this study. And we are working in the Bayesian latent class analysis because the issue with the COVID-19 is there is not a gold standard really. So we need to have a different analysis to try to capture all the information and try to have a better picture of the sensitivity and specificity of this test. And I want to thank all the team in Universidad Peruana Cayetano Heredia, but also the team in McGill University with all the support and all the opportunities that give us to collaborate, to Emily, to Dr. Professor Madupai, and all the team in McGill that help us during this project. And thank you.
And it's amazing how innovation is absolutely born of necessity. So really exciting developments there in using what was at hand. I'm going to move now to, and we're going to have questions at the end. There is the possibility for our audience to place questions in the question and answer session or section. Please do that. Donc, si vous avez des questions, n'hésitez pas à les mettre dans la boîte à questions. And we'll come to the questions at the end due to our bit of a late start here. So next, I'd like to move to Camila Gonzalez Rosas. She's a professor, an associate professor at Universidad de los Andes in Colombia in the Faculty of Sciences. Her field of research is disease ecology with medical entomology as a particular specialty. And she's been working on a variety of tropical infectious diseases such as leishmaniasis, Chagas disease, malaria, and other arboviruses in the region, all the way, and from using a multi-method approach from the molecular parasite-host interactions to spatial analyses on species distributions under climate change. So we're very excited to have her speak to us today. She's an experienced international collaborator, and she will be presenting to us today on her alternatives for viral diagnosis in remote locations. Over to you, Camila.
Thank you, Dominique. Thank you very much also for the invitation of being here. I'm very excited. So I will show you some of the projects that we have been developing together with our Canadian partners and the strategies that we have established to try to provide some alternatives for the diagnostics for COVID. So, I will be sharing the slides. Next one. So, as most countries, the strategy that we had here in Colombia was to respond to the pandemic by increasing the testing capacity, mandating strict lockdowns, and introducing contact tracing, and also by increasing the ICU capacity. The strategy for testing was to perform the diagnostics to anyone with symptoms. However, the number of the tests performed is low compared to Canada and Chile, for example. So this testing capacity required to also increase the number of laboratories or hospitals with the necessary equipment to perform the PCRs. So next, please. And as you can see here, we can see in the map the number of laboratories that have the capacities established by department. And as you can see, almost half of the country doesn't have this capacity. The epidemic in Colombia has had so far 3 peaks. The last one was dominated by the Mu variant, and we have Delta introduced a couple of months ago. And although we have some good vaccine coverage, we are sure that we will keep having this an increasing number of cases, and so detection will keep being one of the major goals. So the challenge we have in Colombia, and that's why we are focusing on remote locations, as you can see. And next slide, please. The challenge that we face is that, as you can see here, the country has challenges in the access to the hospitals and ICU units. Here I am showing a figure that was made by a group of researchers from the university, and they are showing all the Afro and indigenous communities that are located in remote locations and the distance that they would need to travel to reach these health facilities. So as you can see, all of the Amazon and Orinoco region, which is in yellow here, and the purple region on the Pacific coast, even if the distance seems to be not that large, there is also a problem with the accessibility. So if they would need to travel to these health facilities, they would need to have access to planes or boats, which are not easily reachable. So next, please. Here you can see in the small map and shown in blue, where are the regions that are completely missing any diagnostic capacity. So we have at least 7 departments in the country that are not necessarily the most populated areas, but are very large, and the communities are very spread. So it's hard for them to reach diagnostic capacity. And all of the samples from these patients need to be sent to the capital city in Bogota, which is in the center of the country, to be processed by the National Institute of Health. So this will mean that the diagnostics will possibly arrive few days after the symptom onset, and so we are not being able to do a proper contact tracing or contention of the infectious people. Next, please. So one of the initiatives that was very powerful during the pandemic, I would say, was that universities which had the capacity to perform diagnostics decided to join efforts with the National Institute of Health and provide this opportunity for to perform diagnostics. So at the university where I work, a diagnostics lab was set, and we could perform a large number of tests, and we provide support. This was everything was funded by donors at the university, and so we could perform all of these tests, and this also gave us access to have samples in the lab that we could use for the research projects that I am going to show you. Next. So one of the first projects that we established, and now we have two collaborations with Dr. Keith Pardee from the University of Toronto, was to try to apply a previous experience that he had developed on diagnostics for remote locations and try to apply this for the diagnostics of COVID. And here I am showing the title of the two projects that we are performing together. So I am going to show you what we have been doing. Next, please. So the first project is based on the implementation of this device, which is called the Plum device. And this device was used by Pardee and collaborators in previous projects for Zika detection. So the technique we are using is an LAMP molecular technique. And what we can do with this device is to have an isothermal reaction. So the device will heat the samples to a given temperature, and then the reaction of the LAMP reaction will occur, and we will be able to use either a colorimetric or a fluorescent response to be able to detect the positive samples. So this device has been updated, and now we have a fluoroplum, as you can see there, the name. So this is the device that we will be taking to the field, hopefully very soon, early next year, to detect positive patients. And in addition, next, please. Well, in addition, it will be detecting also antibodies. So far, what we have been doing is testing at the lab with the samples that I mentioned that we had access to. And so far, we have these values of sensitivity and specificity. It does detect low CT values. So what we are targeting are infectious people. Of course, we will maybe miss some of the positive patients with very high CT values, which is somehow correlated with the viral load. And so we think that we have reached good values to be able to catch the infectious people, and in this way we can direct some strategies in the field, very rapid response. Next. And this is the ELISA, so the same device will be useful, not simultaneously, but we can first run all the molecular reactions to detect the virus, and then we can also detect antibodies, which is useful to have a a proxy of the immunity of the population. So this is the first project. Next, please. And by developing this project, we faced many challenges. I guess that as many other countries, we had problems with access to reagents, excessive shipping costs. The reagents sometimes were in low quality because they were losing the cold chain. And so we were very aware that in order to keep this diagnostic capacity going, we would need to look at other strategies. So next, please. So we started to collaborate in a second project with Dr. Pardee, and this project involves also collaborators from other countries. In America, we are collaborating with Brazil and Chile, but also India. And the main purpose of this project is to reinforce local capacity to produce reagents and to try to have some autonomy to tackle these difficulties that I was talking about. And as a part of this collaboration, next please, we could send a project to the Ministry of Sciences here in Colombia, and we got funds for the project, and this is the title, Molecular Kits for the Diagnosis of Febrile Diseases of Wide Circulation in Colombia. So the main objective of this project is to do something similar as Cesar was mentioning, is to optimize the access to optimize the sample processing by detecting more than one disease simultaneously. So what we aim is to be able to see if one of the febriles, if the febrile patients that we are diagnosing have multiple diseases occurring, because that's something that we are really interested in. So this was what I was going to show you. Unfortunately, I don't have any pictures of the field work in remote locations, but hopefully early next year we will be going to these settings to perform the test that I just showed. Thank you very much.
Thank you, Carmen. That's really fascinating and exciting prospects. We can think of this as silver linings to what a global pandemic has created in terms of an opportunity for innovation and application to other problems. And if this can help improve diagnosis not only of SARS-CoV-2, but other viruses in remote locations, it will really be a tremendously applicable solution, not only in Colombia, but worldwide. So that's very exciting. I'd like to introduce now Robert Hakisa. Robert, you're there, that's great. Robert has a background in agriculture and became very interested in migration and refugee issues and pursued further studies in that area. And although Robert was born in the Democratic Republic of the Congo, has lived in Uganda since 2008. He's co-founder and executive director of the Young African Refugees for Integral Development, or YARID, in Kampala. He is also a founding member of Refugee-Led Organizations Network and the Global Refugee Network. He is a TED Fellow and an Aspen Institute New Voices Fellow and an Obama Foundation Emerging African Leader. He'll speak to us this morning about frontline COVID-19 responses with urban refugee youth in Kampala, Uganda. Over to you, Robert, and thanks for joining us.
Thank you so much. Good morning and good afternoon or good evening, that's where you are located. I know time differences is very, very big. So Thanks for my introduction, and I'm very happy and honored to be part of this session, which is really very an interesting one to me, and because it really touches what we've been up to, especially in this very difficult moment of COVID-19 here in Kampala, Uganda. So I'm going to talk about our experiences and as during this particular moment of COVID-19 as a community. We've been doing to try to support the communities. Next, please. So as I said, I'm the director and co-founder of Young African Refugees for Integral Development. So YARID is registered as a local organization in Kampala here, and it was founded in 2017 by Congolese refugees here in Uganda. So YARID unites urban refugees through avenues like sports, English classes, and the vocational skills training in order to address social issues and ethnic conflicts, unemployment, public health, and the lack of access to education. So come primarily from the Great Lakes region, but in addition to that, we do also have refugees coming from other countries like South Africa, Somalia, and also Ethiopia that are part of fisheries. Next, please. So the mission of YARID is to empower refugees, asylum seekers, and other displaced persons to overcome the burden of deprivation and the vulnerability to become healthy, educated, self-sustaining, and contributing members in society. So all activities that we're implementing as YARID as refugees to become self-reliant and also to integrate into the new society. Next. So as far as the impact of COVID-19 on urban refugees youth, as an organization, I can say that initially our primary target was looking at the young people, but since we were growing up, we extended this support to more other refugees, not necessarily the youth. Right now we have actually all the age groups, but with the majority dominated by the young people. As you know, when you look at the statistics, they are the majority when you look at the population of refugees in Uganda here. So when the COVID-19 started, as you know, just as in all other countries, so Uganda government was forced to put in place a total lockdown that restricted all the people, including the refugees living in Kampala here to move, and everyone was forced to stay at home without any movement. And as you know, like majority of the refugees here rely on small businesses to make a living. So, and this is happening on a daily basis. That means if people don't move, it will be very difficult, to have a food meal on the table at the end of the day. And this has affected many of them because just the next day, 1 or 2 days, they started crying, for help. And especially since they couldn't, many of them couldn't have access to food. So this increased actually the poverty that we're living in. As you know, naturally, most of the refugees, that say they live in the slums, so where they can only afford one single room for the whole families. Getting food is a struggle. If a woman doesn't walk the whole day, you cannot get the food. Actually, the situation increased, actually the poverty increased, hunger. People could not get food. They started crying for help because they were very hungry. And the increased migration to refugee camp and back to DRC. So we've seen so many refugees, though there was the restriction for movement, just because many of them could not even manage to get food. Some of them even walked walked from Kampala here to go back to the settlement, hoping that they could find some food there. And they've got also information of those who actually to walk back to DRC so that they can see if they can survive there where they are moving. And on top of that, and the stress, many of them are stressed, and when you're in this such situation and of lack of food, if you're a parent, you see your children do not have any food to eat, it increases actually the stress. And I've seen so many of them being in this such situation, it really affected very seriously their well-being. Straight, next please. So as Yaritz, when people started crying for help, there was no way we could sit down and look for how people were suffering. And quickly, because as you know, one of the approach that we're using is working directly with the community. And I'm happy that directly when this happened, we managed to organize Yaritz members and the other volunteers. And we started moving around the city to see how we could support those who were in a critical situation. We did not have anything at that moment. And I remember at that time, I started fundraising using my network on WhatsApp, contacting people. Hey, can you support here? We're having this situation here. People are crying for help. And I raised some money. And later on, we organized another online fundraising and managed to raise up to 5,000 USD that we were able to buy foods. And these foods, we used volunteers using bicycles and motorcycles, and we started moving door to door to reach out to the people who needed the foods, and especially the old people living with disabilities, people with chronic illnesses. So we started moving door to door to have this food distributed, food and non-food items. And this actually was a release to so many of them. So later on, we managed to secure some funding from the Open Society Foundation when they what we've been doing during that particular moment, and they accepted to give us some funds that allow us to procure a big quantity of food. And with the permission of the local district person, we managed to get the permission to start moving around to make food distribution to all the communities in Kampala. And this is how we managed to support a number of them who were in a critical situation and who were in need. Next, please. As you know, the situation of lockdown, of course, we had the first lockdown, and then they reopen up, and again, because of the next wave, and the government was again forced to put people in the next lockdown. And this again, that period of time, we were able to continue extending this support by providing, like you can see on these pictures, where we are giving not only the food, but also the face mask to the people in the communities so that they can be able to protect themselves against this deadly disease. Next, please. So as a next step, since we know that and we will understand how this COVID-19 affected so many people, and especially the people who were involved in their businesses, you're going to see like many of them individuals who were doing businesses during that period of time, they couldn't keep their capital. They just used it to buy food. You find that even those who had capital, it's always a small amount of money that cannot even take someone for over 1 week or so. So we thought of since the situation started getting back to normal, we thought of continuing supporting the people, and we thought of providing a startup capital so that the people can go back to their business. Good enough, the government has allowed the people to start conducting the small businesses with the support that we provided to the people, small amount of money. It allowed them, to start getting back to their businesses. And of course, we continued with the support of the community mobilizers. We continued sensitizing the communities and raising awareness about the COVID-19, moving to different communities to share information about COVID-19 and how people can protect themselves. And also another thing and a critical role that we're trying to play is to make sure that the people in the community there get the right information, because in most cases, the information that was shared, and is being shared by the Ministry of Health and also the government, we find that it's actually in the languages that the refugees in the community cannot hear. So our role here, whenever there is a message, we try to translate it in the languages that the people in the community, refugees can understand, and using the community volunteers, we start spreading the message so that they can get any information that is coming on. So, and this situation also, if they look now, it's increased a lot of protection issues in the community. We've seen a lot of violences increase, starting from domestic violences in different communities, in different households. We've seen increased number of violence against children, early pregnancies, and so on. So in this processes, as the organization have been trying, again with the support of the local community mobilizers, to try to identify these different cases in the community of cases of violence, of abuses, and then we bring them to our desk. And also we've been trying to encourage people in the community to come to our protection desk to say whatever problem they are facing. And some of these problems, and many of them actually, we are not able to respond to them because of our very limited resources. And in this, we also try to work with different partners in the urban area here, where we work on referral basis so that we can have many of the refugees who are coming to us, or those who are we identify in the community, to get support. And this is something that we are trying to do up to now. And since we are still actually up to now in I can say partial lockdown, we have seen this number of cases increasing, and at the same time we are trying to see how we can support them. I think because of time, let me stop here, and I thank you so much for your attention, and I'm very open to any questions or comment. Thank you so much for the organizers of this session. Thank you.
Merci, Robert. Thank you very much. Really compelling stories of how community organizations such as YARID and others were really called upon to step in to provide services in support of communities trying to respond to this threat, particularly not only in very vulnerable communities such as the communities you were working with, but really around the world, where civil society organizations had to step in, whether it was food insecurity or violence prevention, as you say, or simply getting the message out about what the pandemic was and how to protect oneself. So really, congratulations and compelling work. And I'm hoping we'll have a chance to have a bit of discussion after the presentation. So apologies for rushing you a little bit. I'll go now to Dr. Carmen Logie. She's an associate professor at the Factor Inwentash Faculty of Social Work at the University of Toronto, and a Canada Research Chair in Global Health Equity and Social Justice with Marginalized Populations. Dr. Logie's research advances the understanding of and develops interventions to address stigma and other social ecological factors associated with health disparities. And I'm sure the pandemic has created not only the project she'll be talking to us about today, but many new questions or exposing old problems through the lens of COVID as well. Today, she's going to be speaking to us about also work in Kampala, the Kuka Salama, Staying Safe, Interactive M-Health Intervention for Increasing COVID-19 Prevention in Urban Refugee Youth. So over to you, Carmen.
Thanks so much for having me. And this is really a collaboration with Robert Hakiza Yared that builds on, I think it's going on 5 years now of research where we initially started looking at HIV and sexual and reproductive health together. And then with the emergence of COVID-19, we wanted to address the needs that Robert really comprehensively and thoughtfully detailed in the previous presentation. Next slide, please. And so when we put this original grant together, the Lancet had declared a global call to action for the inclusion of migrants and refugees and COVID-19 responses, talking about the exclusion and multiple barriers to healthcare faced by migrants and refugees, among whom COVID-19 threatens to have rapid and devastating effects. Robert just spoke to you about some of the rapid and devastating effects we have noticed and that have been global, particularly regarding increased food insecurity and forced relocation due to not being able to afford to stay in informal settlements, for instance, relocating to refugee settlements where people could get a food parcel. Next, please. So some really brief context. There's 82.4 million forcibly displaced people across the world. And many of these forcibly displaced people live in poverty and overcrowded living conditions with limited access to water and sanitation hygiene. These both increase exposure to COVID-19 as well as create barriers to preventive practices. And we know that adolescents and youth comprise 42% of the world's forcibly displaced people, yet there is a real lack of attention to adolescent and youth perspectives and experiences in pandemics. And so this is a collaboration with Yared, with Robert Hakiza, and wonderful colleagues on the ground in Kampala, building on our work, where they work with 90,000 urban refugees in Kampala, and more than a quarter are aged 15 to 24. And so this study really aimed to fill knowledge gaps in pandemic responses with urban refugee and displaced youth. We used a community-based approach. So this was developed with Robert and Yared. We've been working with a team of 12 youth peer navigators since 2017. These are refugee youth, probably now aged 20 to 25, who live in the same informal settlements. And so we leveraged a study that was recently completing, which was a cohort study on HIV prevention with refugee youth in 5 informal settlements. And we continue to engage the peer navigators. Next slide, please. And so initially we were planning to implement the RANIS approach, which is a systematic behavior change approach for water and sanitation hygiene that looks at social, physical, and personal contexts. And RANIS stands for risk, attitudes, norms, abilities, and self-regulation. And this was a mixed method study. So in phase 1, we conducted 24 in-depth interviews with urban refugee youth in Kampala and 6 key-informed interviews. Those were used to develop content for a text messaging and WhatsApp intervention, which was an 8-week intervention where we had 2 different text messaging or SMS messages. One was a general check-in, how are you, on Mondays. On Wednesday was an informational text message inviting people to share a response to a question I'm going to give an example to. And finally, we asked people to share, if they wanted to, de-identified photos of them engaging in the weekly activity, which was actually quite amazing. People put emojis on their faces to hide their faces. I'm going to show you some examples. And then we had survey collection before, directly after the intervention, and 16-week follow-up, which just completed last month. And now we're in the knowledge mobilization phase. Next slide, please. So this is a general study diagram where you see our primary outcome was around prevention practices, and the secondary outcomes were around the RANIS, but also depression and sexual and reproductive health practices. So as I mentioned, there was a weekly SMS check-in and 8 weekly topics. And we ended up expanding beyond water and sanitation hygiene to address the social determinants of health based on, you could hear from Robert's discussion from our qualitative data. So we looked at mental health, vaccine hesitancy, hand washing, mask wearing, economic stressors, COVID symptoms and testing, and COVID signs and recovery. And the final week was a recap of the weekly topics. I also wanted to note that at every survey collection time, we had a prevention parcel that included masks made by refugees in the same settlements we worked in, hand sanitizers also made by local refugees, and a food parcel. Next slide, please. So I'm just going to give you a couple of examples. For example, the weekly message example of mask wearing. Our text message was and this, everything was done in 5 languages: English, French, Luganda, Kinyarwanda, Kirundi, and Swahili. So wearing a mask can protect yourself and others from COVID-19 spread. In crowded areas where social distancing is hard, masks can help keep you safe. And then we asked, let us know why you wear your mask. And then we had the peer navigators meet every week and choose a winning message. So the winning message was, we know that things are hard with lockdown. So most of you replied that I wear my mask to protect myself, my loved ones, and the community from COVID-19. We know times are hard with lockdown. We are here to support you. Please contact your peer navigator if you need information. And you see a photo there of 2 people wearing masks that they sent in. They provide ethics approval to share these photos as for research purposes. Next slide, please. And in the second example I'll give, the weekly message was on hand washing. So the text was regular hand washing and sanitizing can help reduce COVID-19 spread. Try hand washing before and entering public spaces. Why is hand washing important to you? And people wrote, so the winning message was, most of you replied, it is important for me because this COVID-19 spreads. If I touch something, I wash my hands before, the COVID-19 will die. Let me continue to learn how to live a healthy life. And those are photos people sent in on WhatsApp of where they wash their hands. So we asked, send us a photo of where you wash your hands. Next slide, please. And so the preliminary feedback was really positive. People asked about wanting more information, thanking us. And we have, a lot of people also expressed that they needed money and they needed financial resources so in addition to this information. So our next steps, we have a mental health grant that we're just starting now. We just applied for a livelihoods grant a couple of weeks ago. And we're in the process of knowledge mobilization. And the last slide is, next slide, is as part of our knowledge mobilization, we're creating a comic book that goes over each of the 8 weekly topics. And this is also going to be done in all of the study languages. Thanks so much. I'm done.
Thanks, Carmen, and that's great. I mean, I was just squinting to see that great cartoon. It's so it's really exciting, I think, to see how this fund that Canada mobilized in the early months of the pandemic led not only to really exciting medical countermeasures research, but also supported research in this whole social aspect of how you actually get people to take up even the simplest but really effective public health measures. So really exciting. And I'm going to come at the end of the panel with a question. So I'm priming you now for all of the teams on this Canada international collaboration dimension, which as IDRC we're very interested in. And is the feature of a lot of our work on public health emergencies. So would love to come back to that. I'm going to go now to Peter Newman. Peter is a professor also with the Factor Inwentash Faculty of Social Work at the University of Toronto, and he's also affiliated with the Joint Centre for Bioethics. He is a former Canada Research Chair in Health and Social Justice and an inaugural fellow of the U.S. Society for Social Work and Research. Accomplished researcher and highly published, as all our panelists are today. His research addresses global health and human rights, HIV, and sexual health, and he has led also a social science and humanities research council partnership with an 8-country multidisciplinary team addressing all dimensions of evidence to to help promote inclusion of LGBTQ plus communities in Asia. Today, though, he's going to be talking to us about an e-health intervention on knowledge, behaviors, and mental wellness of the LGBTQ plus people in Thailand. So, and this is the Safe Hands, Safe Hearts project. Over to you, Peter.
Thank you very much for the introduction, and it's great to be a part of this panel. Yeah, so today I'm presenting on the effect of an e-health intervention on COVID-19 knowledge, behaviors, and mental wellness of LGBT plus people, the Safe Hands, Safe Hearts randomized trial. So we endeavored to conduct a randomized controlled trial of a brief intervention, but specifically tailored for sexual and gender minority populations in 3 countries, localized in Mumbai, India, in the Greater Toronto and Hamilton area in Canada, and in Bangkok, Thailand. And my colleague who has coordinated this project in Thailand, but also really across the globe, will also speak later a little bit to the Thai experience. So just basically, there are some shared vulnerabilities, particularly across India and Thailand, in terms of India vastly underfunded healthcare system way before COVID, and of course Canada has a much more well-funded healthcare system and also social welfare programs available across the board. But what is shared across the countries, within each country, are disparities in health and mental health among LGBT plus persons. And some of these disparities themselves create more vulnerability to COVID-19. I think it's important just to introduce that whereas if I were talking about older adults, it's clear there's immediately vulnerability across the board for all older adults. It doesn't matter what your social identities are. And certain other populations, people with disabilities, across the board, there are vulnerabilities. For LGBT plus people and for other racialized populations, it's really important to talk to and speak to marginalization, which are structural and social factors that produce inequalities before COVID, that they themselves, in terms of the health and mental health disparities, even prior to COVID, create vulnerabilities. But importantly, the same disparities in social determinants of health then also exist during COVID and really create a situation that's it creates extreme vulnerability. So just briefly, even within Canada, from Stats Canada, I mean, to their credit, they've even published maybe a year or so ago, evidence of the economic marginalization of LGBT plus populations who are often earlier in the work career in various companies with less secure positions, more likely to be laid off first when there are economic crunch time. In all 3 settings, there's higher rates of violence victimization and health and mental health disparities among LGBT plus populations. And another important factor, and that's what we really jumped in to try to deal with, is there's not necessarily any malintent or malice as part of it, but pandemic response planning, to the extent it exists, is normed on largely heterosexual people and the notion of families that are nuclear families of heterosexual people. Now, of course, there are some issues that are across the board for all human beings, but it creates certain vulnerabilities for LGBT plus populations when they're not included in the planning, and some of the context and some of the help that's available is not attuned to their needs. So therefore, the purpose of our project was, one, to just look at the needs and challenges faced by diverse LGBT people across these 3 countries, to look specifically at COVID-19 knowledge and public health recommended protective behaviors like masking and physical distancing, and also measures of psychological distress. And then to see if our 3-session peer-delivered e-health intervention could make a difference. Just one facet of the design that I want to emphasize is this is a waitlist controlled intervention. And the notion is that we just couldn't conceive it as being like, strongly ethically supported to have a waitlist group that wouldn't get the intervention when we've already made an argument for why this is potentially a highly vulnerable community, and then on top of that during a pandemic. The challenge for us then is we had to provide the intervention to all participants, which is proving challenging, but we're moving very, very strongly forward. So overall, our target is 900 people across the 3 different sites. And also importantly, within each site, we stratify the sample by cisgender men, cisgender women, and transgender men and women, and also gender non-binary people. So that guided by CAHR's gender and sex-based analysis, but also expanding on that to include trans people, we want to be able to compare across these groups, like that there are obviously potentially huge differences within LGBT plus populations. And so briefly, this is an e-health intervention. Everything is online. The development of the intervention was itself online. And this was by necessity in terms of, and particularly in some of the settings we were working in, but quite challenging. And it's undergirded by motivational interviewing and psychoeducation. The basic point about those is that they are client-centered, non-judgmental approaches, which are very, very important for a highly stigmatized group of people, and operate from wherever you're at now. How can we help you to feel more safe and to act more safely and to get support that you need? This is showing you just a screenshot of what it would look like if you sign into the website. And this is, on the left side, Canada, largely in English, several languages in India, and then of course in Thai. And people screened online, went through ethics, and then could ask questions and did a baseline survey. And then, as here it's showing, and then are randomized to either the immediate group to receive the intervention or to a waitlist group that had to wait 2 to 3 months to start the intervention. And I've already went through what our primary outcome measures are. This is showing a dashboard that like we see as we're moving forward. And actually, even since we first submitted the talk, I'm pleased to say that Thailand, we've now maxed out and we've totally made, hit our targets in terms of participants. India is at about 85%, and Thailand and Toronto, Canada is moving forward. I'm just going to show very briefly in terms of some beginning results of that. We actually found, and our purpose mainly is not to compare the countries, but it was stark that the levels of depression and anxiety reported among the LGBT communities in our project in Canada are vastly higher, almost double those in the other 2 countries. Now, I have some thoughts about that in terms of, in Canada, we very specifically tried to target the most vulnerable. So we started off largely with racialized LGBT folks in the intervention. And then just briefly, what we see here is that Canada and Thailand are roughly at the same level in terms of awareness and ability to implement public health recommended measures like masking and physical distancing and hand washing, with India somewhat less than that, which is not unexpected, because that's not only about individual will and agency, it's about structural conditions that enable you to do these things.
And the benefits of the 2 peer counselors and partners from our intervention is that we have now trained over 40 peer counselors across 3 countries. Our e-health intervention helps increase their skills and confidence in counseling, especially around pandemic-related issues that their clients have been facing. This study also facilitates community-based community engagement and support, including implementation of e-health activities using our customized online-based platform to reach clients and participants during such situation, which definitely facilitates skills and confidence in following up and retention. And it is a model for engaging sexual and gender minority communities in pandemic response preparedness. For example, in Thailand, we work with the Tangerine Clinic, which is a sexual health clinic designed to serve transgender community, and the Pripta Clinic for lesbian and women who love women community. And our study implication, it's the first peer-delivered prevention program delivered to through Internet of Things devices such as PC, laptop, tablet, mobile phones for LGBT+ people in low and middle income country during the COVID-19 pandemic. If effective, it has potential for widespread implementation as it is relatively low cost, as it relies on peers. It is culturally competent, adapted with community input in each setting as we consulted and received inputs from community experts. The delivery method is acceptable and accessible for many LGBT+ people, including in LMIC countries, because many LGBT people who live under fear and stigma for being outed and places with higher rate of victimization. This is why the online environment is particularly acceptable and safe for these people to comfortably engage and connect with other peers. And this also makes this delivery method quite feasible to implement during pandemic and other emergency situations.
Thank you. And just briefly, so we were covered in Quebec Science, and they featured particularly, they had luckily a reporter in Mumbai, India, and focused largely on the plight of transgender communities in India, who are facing very specific problems amid COVID that are different than the other populations. And we've also have some beginning publications in terms of also even within Canada, challenges to HIV prevention amid COVID. This is our project website, which is freely accessible, and there's a lot more resources on the project website. This is Notisha Masakoi, who is leading the project for us in Toronto, which we particularly wanted to situate with an agency serving primarily women of color, Black women and other women of color. That's not traditionally where LGBT+ interventions are situated. However, of course, there are multiple intersections of social identity, and that makes this a very vulnerable population. So just want to show some of our team. As I said, Dr. Natisha Masakoi, Dr. Venkateshan Chakrapani at the Humsafar Trust in India, Nidya Panyapak in Thailand, and Suchan Tepchan, who gained his MPH during the pandemic and during this intervention, which is a great step forward in of itself, and is really helping to lead our intervention. So thank you so much.
Thank you very much, Peter and Suchan. Great to have you as well, Suchan Tepchan, who's from Thailand, working in the project, and congrats on completing your degree. Really not an easy time. So wonderful. So thank you very much. Now, audience, if you have questions, you can place them in the live question and answer section of the platform, which you see below you. And while our audience perhaps gets their questions together, I'm going to do a quick round. We only have about 10 minutes left. So audience, if you have questions, do place them in there. Si vous avez des questions, s'il vous plaît, les mettre dans la section questions et réponses de la plateforme. But I would love to hear from you on the collaboration between Canada and your partners internationally, and what's the added value of that for both sides of the story. We're very blessed to have members of teams from Canada and their partners in other countries as well, or the other way around, countries with their partners in Canada. And I would love to hear from you on the nature of that collaboration. Challenges, sure, but what benefit do you draw from that is different from research that you might do different without that collaboration? Who wants to come in? Maybe if you just wave your hand at me, I'll see. Cesar, over to you.
Okay, thank you. I think considering the pandemic times and all the complications, all the problems and challenges that we faced during these 2 years, I'm happy to say that the collaboration with our Canadian partners, especially in this case of this project with the McGill University and the team of Professor Madhu Pai, was very, very good for us in many aspects. And one thing is this idea of to work horizontally, and we, as a peers, work everything of the project. Now we in the develop the project, in evaluation of the project, the follow up the project, the interaction between the young scientists from and the young researchers from my team. The interaction also give the opportunity to my team to interact, and also the young researchers from Canadian part learn from us. So it was very, very interesting and very active collaboration. And these and this honest and horizontal partnership create opportunities to apply for other projects. And we start to discuss how to, as slide, we want to expand this. We want to look for other questions, research questions that arise during this pandemic. So, in short, I think this partnership is necessary to try to, but always with this view of horizontal, and this is not north and south, is equals working in the same ground. No.
Anyone come in on this question? Your experience, Peter.
Yeah, I can just certainly add to that from my perspective, which really aligns with the previous speaker's talk. There's no way in the world, even though this is an e-health intervention, it's online, there is no way in the world we could have implemented this intervention without having strong partners in Thailand and India. It was hard enough doing this right at my doorstep in Canada, in Toronto. But very luckily, these organizations did exist, and particularly in Thailand, they had a whole clinical infrastructure because they've done a lot of AIDS clinical trials. But what was new for them was focusing on psychosocial issues and social support. They do a lot of work with sexual and gender minority communities. So it was really a win-win in that, and they said they really felt that they benefited greatly from that. And I know I benefited immensely by them being able to run this trial, so well. The other thing that was really built into this intervention was that, of course, we need to look at results, and we're going to, do statistical analyses to see what's happened. But built into the intervention is this engagement with partners, and it has to be culturally sensitive, culturally competent, or it's not going to function very well. And two, that we want to leave, especially working with the community-based organizations that are delivering this to their peers, we want to leave them stronger than when we started. Our intervention, as lovely as it is and as happy as I am to be part of it, is going to be gone after another year or so. But they're going to still be there on the ground working with populations. And so that aspect is just very, very much important to our approach.
Thanks. And I just the audience can't see, but I think Robert is there, although we can't see you. Robert, did you want to come in on this question of how the Canadian collaboration has worked with Carmen's team? Okay, we really can't hear you. All right, that's too bad. We have him in the chat, unfortunately. Carmen, we'll go to you.
Yeah, I think it's been this great collaboration because, as you can see, the internet is not always the greatest in Uganda. And so that really helped us listen to local communities and deliver things also by text message. So not everything was by something like WhatsApp that involved needing the internet. Another thing I wanted to say is because the peer navigators are refugees that speak 5 languages and are embedded within communities, we had a 90% follow-up for this intervention, which is really amazing. And it was to the testament of Yared, knowing the community, being embedded in the community, and supporting peer navigators. So for our team, I mean, obviously everything we've done has been in collaboration with Yared, and it's really about training people, you know, about the design of doing a trial, and how do you support people when they're in distress. But their wisdom and their knowledge, persistence and dedication made this a success. I mean, the fact that we reached more than 300 urban refugee youth and maintained connection with them over 4 months in a pandemic. And there was also political crises earlier this year. So it really is a testament to the need for community-based approaches and flexibility.
Wonderful. So we have just a couple of minutes left. Does anyone else want to come in on this collaboration issue or on anything else around lessons learned from doing research in COVID, during COVID? Camila.
Yes, I agree with all the previous comments, and I share the privilege of sharing knowledge and skills with the Canadian team. I think that what Cesar mentioned is very important. We have a group of students and young researchers from both sides that are also sharing experiences, and during all the standardization process and the implementation of the Plum device in the lab, they are faster and more skilled than perhaps the senior researchers in getting things done. So it's very nice to see how they work together, and they have different communication channels. Everything moves very fast with them. So I think that's one of the greatest things that we have been able to do.
Wonderful. Well, and thank you, Camila, for reminding us. Of course, we know that underneath all of this research, there is a tremendous amount of young talent, researchers, young and not so young, but new to the research work in graduate students, and they are so motivated and mobilized to do something about COVID during COVID, but it's a very tough time to also study in an often virtual environment. So congratulations to, and we have Suchan here, but there are others in all of your teams. Thanks everyone for joining us for this conversation today. I'm really delighted to have had the honor to moderate this panel of outstanding Canada international research partnerships tackling a variety of aspects of the pandemic and response to it. I invite you to follow the rest of IDRC's program at the Canadian Science Policy Conference. We're tweeting about that program. We have a program on new technologies, artificial intelligence. We have a keynote panel with our president Jean Lebel. Donc, je vous encourage à nous suivre sur les médias sociaux pour en savoir plus. Merci, bonne journée. Thanks again to our panelists and to our audience for joining us.